Good afternoon, everyone. My name is Catherine Alfano, and I am the American Cancer Society's new Vice President for Survivorship. I am so pleased that all of you have joined us today to kick off this webinar on cancer rehabilitation. I look forward to meeting you in person, I hope, as our time together goes on. I'm going to start today by taking us through a few slides just to set the stage for what our main presenter is talking about today. So, as most of us know, thanks to multimodal therapies and earlier detection, the number of cancer survivors in the United States has really grown dramatically over time. But that's not telling the whole story. We're really facing what I call a tsunami of older adult cancer survivors. Between 2010 and 2020, the number of cancer survivors who are over the age of 65 is going to increase by 42%. That's really dramatic. And why is that important? Because cancer survivors are at risk. They're at risk for chronic effects. These are the problems that are present when treatment ends and can persist for years after treatment, and it might even be longer than that. That's just all the longer that we've studied it. And those are the things in blue, like mental health problems, depression and anxiety, like fatigue, like incontinence or lymphedema, or pain or peripheral neuropathy. And then cancer survivors are also at risk of late effects of cancer. These are the problems that happen, they're not present when treatment ends, but they happen seemingly, they come up out of nowhere. Things like obesity problems, endocrine dysregulation that leads to that, functional limitations, osteoporosis or bone problems. Of course, the recurrences we're really trying to avoid. And what I'm really concerned about as a rehabilitation person is the spiral of all of the impact of this in spiraling someone into disability, and we want to prevent that. And our older adult survivors are coming into cancer with more of these problems already, and then the cancer therapy in some cases is exacerbating those problems. So back when my grandmother was diagnosed with breast cancer, she was a 2-time breast cancer survivor. The picture on the left is how her physicians thought of returning her to functional status. You know, they thought, well, she's an older person, and if we get her back to so she has to be in a wheelchair, that's enough. That's adequate physical functioning. Of course, that wasn't enough for her. She was a feisty lady. But the coming tsunami of cancer survivors over the age of 65, these are our baby boomers. And our baby boomers are not going to stand for that. Our baby boomers are going to be more like the picture on the right. And if you can't tell, this gentleman is in his 80s and he is water skiing barefoot. So our baby boomer cancer survivors are going to expect that we can rehabilitate them to get back to whatever crazy activities they were doing before cancer. So what I'm calling for then is that we really need a new model of cancer survivorship care. And we have many Institute of Medicine reports now that talk about this. So I told you about the dramatic increase of the number of cancer survivors, especially the older adult cancer survivors that are coming in with multiple comorbidities. And furthermore, thankfully, most of our cancer survivors are not going to, or not most, but many of our cancer survivors are not going to die of their cancers. They're going to die of these comorbid conditions. So we need a model of survivorship care that really addresses, prevents, or treats the chronic effects of cancer therapies and that decreases the risk for late effects. We know that physical and emotional issues in our cancer survivors are not being met, so the model of care has to deal with that. And we need to ultimately prevent that spiral into disability that I'm so concerned about. And finally, the model of care has to promote healthy behaviors as well, so that we can deal with those chronic conditions that may be the likely killers of many of our cancer survivors. So the Institute of Medicine had submitted a report in 2005 that talks about the 4 components, or pillars we call them, of survivorship care. And the first one is surveillance. This is the one that everyone knows about. Of course, we need surveillance of our cancer survivors. We need to be looking out for recurrence, for second cancers, and for these late effects, the cardiac toxicities, for example. We need intervention for the treatment consequences. And these are not just medical, but also psychosocial, and also the economic turmoil. We need prevention of recurrences or new cancers to the effect to the extent that we can, and prevention of those late effects and new comorbidities that are driven by the toxicities of our therapies. And then we also have to have a component of care that really coordinates the care amongst primary care providers and all of the different specialists that our cancer survivors need to ensure that all of their needs are being met. So I think that a comprehensive rehabilitation model really does all of these things and presents the optimal system in which our cancer survivors can be treated. Why do I think that? Well, first of all, comprehensive rehabilitation has, by definition, a joint focus on optimizing both the functional status of our cancer survivors and their quality of life. And it also has those components of survivorship care that the Institute of Medicine said were so important: the intervention piece, addressing pre-existing or treatment-related comorbidities and the chronic effects of treatment, the prevention piece, meaning promoting self-management and healthy behaviors to prevent further problems, and it really coordinates care. It prevents that spiral into disability. It helps people preserve whatever their roles are in life, whether that's working or caring for family members. And all we have to do is add in that surveillance piece, and we've got the perfect model. So with that, I'm going to introduce our main speaker for today. I'm so pleased to have Dr. Julie Silver. She's an associate professor at Harvard Medical School in the Department of Physical Medicine and Rehabilitation, and she's also a breast cancer survivor. Following her acute treatment for cancer in 2003, Dr. Silver realized there was a large gap in helping survivors to heal as well as possible from toxic cancer therapies. She wanted to promote understanding of the healing process and help survivors function at the highest possible level. And so she wrote the book, After Cancer Treatment: Heal Faster, Better, Stronger, which offers a step-by-step plan for physical healing from cancer treatment. Dr. Silver, I'll note, is also the editor of our American Cancer Society book, What's Helped Me Get Through: Cancer Survivors Share Wisdom and Hope After Cancer Treatment. Dr. Silver has published extensively in the area of oncology rehabilitation and cancer survivorship in general. She's on the medical staff at Massachusetts General Brigham and Women's Spalding Rehabilitation Hospitals in Boston, Massachusetts. She's also the co-founder of Oncology Rehab Partners. She's a doctor specializing in rehabilitation medicine, or a physiatrist, so she's really uniquely qualified, and I know she's extremely committed to promoting and developing superior oncology rehabilitation services for cancer survivors. She lectures extensively to healthcare providers around the world about the need to create survivorship as a distinct phase of cancer care that includes oncology rehabilitation services. And with that, I'm going to switch us over to Dr. Silver and let her get started.
Great, thank you so much. It's a pleasure to be here and to be able to have the chance to talk to all of you. And that was a really great introduction in terms of what the American Cancer Society and the vision of the Dr. Alfano and what the future holds. Very exciting. I love the gentleman barefoot water skiing. That was excellent. So the objectives that you all saw when you signed up for this webinar are as follows, and I really broke it up into several parts. And part one is really about exercise and wellness versus impairment-driven cancer rehabilitation. So I wanted to just use a bit of an analogy, because a lot of times people do get confused about what general exercise and wellness is versus impairment-driven cancer rehabilitation. And they're really, part of the same family of services, but they're different. So here I have, the orange, that's the impairment-driven cancer rehab, and the apple that is general exercise. And as we get into, looking at exercise, we know for sure that apples are really, really good for us. We also know that not all apples are the same. And so as we look at exercise and we think about fitness and fitness professionals and so on, we know that there's a lot of variability in exercise programs, exercise recommendations, and so on. One of the wonderful things that has happened over time is that the American Cancer Society and the American College of Sports Medicine have teamed up together to develop a cancer exercise trainer. And this is a certification that helps fitness professionals really learn how to specifically recommend exercises for cancer survivors. And this is in the category of general exercise and wellness. That's really terrific. Livestrong has also teamed up with the YMCA, and so you can see here that the qualifications are a bit different for the Livestrong program, but the idea is the same, that the people that are trained here are able to help cancer survivors with their fitness needs. So as we look at impairment-driven cancer rehabilitation, this really talks about what Medicare would call skilled care, clinical care. This is medical care. And this has to do, you know, the professionals in this have many years of formal training, and they work in hospitals or clinics, and they're taught to work collaboratively with other clinicians. And there's quite a bit of education and formal licensure and board certification and testing and so on that goes on in this. And health insurance does cover this medical care because it is defined as medical care. So when we look at impairment-driven cancer rehabilitation, you know, we have lots of problems that people have throughout their bodies, and we think about, all right, what would the prescription be? If this is medical care, what are we actually going to prescribe? Who's going to be consulted and so on? And certainly physiatrists have a big role in rehabilitation medicine. These are the physicians that are usually involved. Physical therapists, occupational therapists, speech therapists, mental health consults, neuropsych, and so on can be involved. It really depends on what the person's problems are. And so in different patient populations, we see different problems. And even within a single patient population, for example, breast cancer or head and neck cancer, we're going to see a lot of variability in the problems that these patients have, the impairments, based on their age, their premorbid condition, the kind of treatment they have, how they react to that treatment, and so on. So these are pretty complicated medical problems that we're talking about. So one of the things that Dr. Alfano and I were talking about was, gee, you know, how big is the problem of impairments in cancer survivors? And there's a lot of different studies on impairments, but this is one that I just, you know, these are actually a couple of studies that I just wanted to highlight. One was done in 2008, and one was just released in 2015. So looking at this one in the study of 163 women with metastatic breast cancer, how many had impairments? 92%. That's a lot of impairments. How many were, you know, total impairments were documented? So basically saying, did these women have more than one impairment? And the answer was yes, absolutely. They had quite a few impairments, each person. And then how many were treated? On the outpatient side of things, ambulatory care, which is where most impairments are treated, it was less than 2%. So, you know, how did we do in 2015 looking at this? Well, this is a different population, 529 older adults with cancer, and 65% had potentially modifiable functional deficits needing PT and OT. And then how many received PT or OT? Only 9%. So we know this is medical care, and we know that there's a really big gap in care, and that the science has consistently shown us that. The science has consistently shown us that a very large proportion of cancer survivors have impairments that are potentially modifiable, and that very few of them actually get these services. So big gap in care. And one of the things that I did with colleagues is I wrote this article for the American Cancer Society's journal, CA, on impairment-driven cancer rehabilitation to really talk about, you know, what the second part of this says, which is an essential component of quality care and survivorship, to explain that this is really different than general exercise, and what we're talking about are treating these potentially modifiable impairments so that we have less disability in these patients. And this actually was taken by the American Cancer Society and for the first time incorporated impairment-driven cancer rehabilitation into the facts and figures. So the American Cancer Society has done a really nice job of leading the way with this idea of supporting impairment-driven cancer rehabilitation, and I'm excited to be working with Dr. Alfano, who has a real vision for this, taking this into the future. So what does a best practices cancer rehabilitation model look like? You know, obviously a physician is usually involved in medical care, and in cancer rehabilitation it's often a physiatrist, and then you're going to have an integrated team, interdisciplinary team with PT, OT, speech, nutrition, mental health, etc. And then, of course, you have fitness professionals. This is a really great handoff, very important member of the team as well. And again, fitness is usually not reimbursed by third-party payers, and I know people get upset about that, and it's, you know, it's just the way it is, that at this point it's not. Certainly, you know, there are people that advocate that it should be. And so then we look at the, you know, sort of where the impairments are treated when you look at these models. And if the handoff is just from an oncologist or a primary care doctor to a fitness professional, the impairments will not be treated. And that's fine if there aren't impairments to be treated. But the impairments really have to be treated by that clinical, integrated, interdisciplinary rehabilitation team. So that's really important to just remember that both models work, and you want to have both of them, but you have to identify the impairments, and some patients will go to rehabilitation and other patients won't really need it. So when we say, all right, how many patients are actually going to need the rehabilitation? About 65 to 90%. And then if you say, all right, how many people actually need general exercise? Well, more than 90%. Almost everyone's going to benefit from some general exercise, which is great. So these two things actually work very synergistically, hand in hand, but they are different. So when you look at sort of triaging patients and you think about impairments, you're going to make sure that the patients are screened, and that if they have impairments, they're sent for rehabilitation. So what does this really tell us about apples and oranges? You know, basically, if there are 10 cancer survivors, then 1 to 4 of those patients would be apple only and get general exercise and wellness only. And 6 to 9 of those survivors should be referred for cancer rehabilitation plus general exercise and wellness. So they're an apple and orange patient. So what happens if survivors who have impairments don't get rehabilitation? And this is really interesting to think about. You know, impairments are what you physically see on patients, you know, the physical examination and so on, the kinds of medical problems and conditions that patients have. But disability is a result of the things that someone can't do because of the impairment. So disability is a really big issue that's related to impairments, but it's distinct from it. So what happens to a lot of these patients is they do become disabled, and it costs society a lot of money, it costs them a lot of money, and so on. And there's quite a bit of documentation around that in the medical literature. So to kind of take a break from, you know, just talking about the research, I thought that I would put in a case of a typical patient that I often see. So Mary, she's 55 years old, and she was diagnosed with right-sided stage 2 breast cancer. She undergoes, you know, very typical treatment for a breast cancer patient, and she's now getting an aromatase inhibitor. So let's follow her through and see what happens to her. And this is actually a case that I published in Value-Based Cancer Care, just kind of showing the cost saving. So Mary's complaining of shoulder pain that awakens her at night, and this is on her affected side. So there she is. She's rolling on her shoulder at night. It wakes her up, and she goes on the computer, on the internet, and she says, oh my goodness, I have night pain, cancer and night pain. That's a red flag. Maybe my cancer has come back. I better call my oncologist right away. So she calls her oncologist, and the oncologist is sitting there thinking, does Mary need a metastatic workup? So that's a tough question. At this point, we don't really know what Mary's shoulder, we don't have any baseline. So we don't really know what's causing her pain. We can probably guess that she's got some musculoskeletal pathology in her shoulder that's causing this pain, but we don't really know, and it is on the affected side. So when I ask a group of oncologists, show them this case, and I ask them to raise their hands, most people do a metastatic workup, and I think that's probably appropriate. Now, if she had a baseline assessment, and we knew that it was, for example, rotator cuff impingement, then we would be probably less likely to pull the trigger on a metastatic workup for a musculoskeletal problem. Rotator cuff impingement probably is the most likely diagnosis. What treatment is recommended? What could have been done to prevent this? So we get into, looking at physical therapy, different kinds of things that can be done to treat rotator cuff impingement. And now she's actually, you know, she's not really able to lift her arm overhead, so her shoulder has actually, that rotator cuff impingement that was pretty, you know, pretty minimal to begin with, has sort of progressed to a frozen shoulder, which is called adhesive capsulitis. So when we look at not getting a baseline and so on, you know, we're looking at she's returning to work a year later versus 6 weeks, and the total direct cost is significantly more. And we've cost her a lot of stress too, because here's Mary. She's been really, really worried about this. She's been waking up at night. And one of the things I want to just point out is Mary, she's an office worker, so she works on a computer. And so the rotator cuff really stabilizes the arm above 90 degrees or so. So she can actually work on the computer, she can get herself dressed and do all the things that she needs to do and so on. So why doesn't she return to work? Why does it take her a year to go back to work? And this is a pretty classic symptom cluster where someone has one problem and that sort of generates other problems. So there she is with her shoulder pain, and she's worried about it, and she's having trouble falling asleep at night because she's worried in the middle of the night that she's going to wake up with pain, and that makes her anxious, and so she gets up in the morning and she hasn't really had a good night's sleep, and she's very fatigued, and so on. So the sentinel symptom in this, and when we look at clusters, we often talk about sentinel symptoms. The sentinel symptom in this is the shoulder pain. Mary would have been a lot better off to identify that early rotator cuff impingement, have it treated, and not have to get the metastatic workup and not be out of work for a year and so on. So that's a pretty stressful case for, you know, or treatment for Mary. That's similar to Mary, but during her prehab, she's noted to have no upper extremity dysfunction. So now we do have a baseline. We have a baseline, and we say, okay, there's no upper extremity dysfunction. 8 months after her acute treatment, though, she's complaining of pain around her elbow on her unaffected side and dropping things. So now we're talking about the unaffected side. This is interesting. It hurts to use the mouse on the computer and to hold her cell phone. Does she need a metastatic workup? The truth is, I saw this patient, and she was, by the time I saw her, my medical assistant came up to me and said, Dr. Silver, you know, she is so upset. She wants a metastatic workup. You're going to have to do that as a first step because she is really, really, really upset about her pain and what's going on. So I actually did it, but I knew it was going to be negative. Then I said, well, what's the most likely diagnosis? So she's complaining of pain around her elbow on her unaffected side. Probably a lateral epicondylitis. You know, this is a tennis elbow. And why does she have this on the unaffected side? Honestly, it's overuse because she never had her affected side rehabbed. So there she is. She's had surgery and so on the affected side, and now the unaffected side is going to do a lot more work, and it's not used to doing the work of both arms, really. So we see a lot of overuse injuries on the unaffected side, and people get metastatic workups for these musculoskeletal problems. All right, so moving on to Juanita, and she's similar to Mary and Beth regarding her cancer diagnosis. And she was diagnosed about 6 months ago, and now she's complaining of getting her thumb stuck on her non-dominant hand. And we wrote this case up, actually, and presented it at the American Congress of Rehabilitation Medicine. And one of the things about Juanita is that she is a portrait photographer. And this is actually true. She is a portrait photographer. And she had to use the computer a lot to try to get rid of the blemishes on high school students' faces as she was trying, you know, she did a lot of school portraits and so on, so all the acne and all the blemishes and everything had to be removed, and she literally could not do her job. So here we are with Juanita, and does she need a metastatic workup? She actually got one before she came to me, and, you know, does she have one diagnosis or two? Well, one of the things to think about is what's causing, you know, what's causing this, and what are the diagnoses? So the thumb getting stuck is a pretty classic trigger thumb or trigger finger. The numbness and tingling on her dominant hand, that's probably going to be carpal tunnel syndrome. And here's why. Because aromatase inhibitors, we all know, or most of us know, that aromatase inhibitors cause arthralgia. But what a lot of people don't realize is that they affect tendons too. So there we have the tendons affected in her hand, and there's some literature to you know, support this, that aromatase inhibitors do affect tendons. So she has a trigger thumb, but why is it causing carpal tunnel syndrome? The reason is because the median nerve goes through that carpal tunnel with a bunch of tendons. And when those tendons get irritated and they get inflamed and so on, there's less room for that median nerve to go through. And so it's very similar to, you know, how women who are pregnant get carpal tunnel syndrome and so on. When you change the pressure in the carpal tunnel, the nerve gets pressure on it. So how many impairments did we just discuss? We discussed, you know, quite a number of them, and there's a lot more in breast cancer patients alone that people don't talk about. A lot of times people go straight to lymphedema as like the main concern in breast cancer survivors, and yet there's so many other problems. And this is actually a textbook that I edit with a couple of other physiatrists on several, probably at least 200 physiatrists and others contribute to the content of this. And you can see some of the chapters, and you also see the codes, ICD-9 and ICD-10. And those are really important. Sometimes when I lecture, people say, well, could you just give us the codes to use so that we can code properly for different diagnoses? And one of the things I say back to them is, if you're a clinician treating these problems, you should actually know the code. And if you have to look up the code, that's fine, but and this is a really important but, your documentation has to support whatever code you're using. And that documentation has a lot to do with your clinical training and what you understand and so on. So it's not about getting a list of codes. It's about understanding the evidence base, getting the clinical training, and making sure that your documentation supports your treatment of that patient. So very important. So we did talk a little bit about sort of the difference between general exercise and wellness versus impairment. And now I want to talk a bit about distress and quality of life, because it's really important. So there's been quite a few studies, and I thought I'd put up just a few examples. I'm not going to talk about these at any length because they're just examples, and there's many, many examples. But just kind of looking at quality of life and symptom distress, there's a very close relationship between quality of life, disability, symptom distress, and physical impairments. And the research is very, very compelling in terms of more cancer survivors have decreased health-related quality of life from physical problems than they do emotional ones, and that the physical problems often are the driving force behind the emotional ones. And there's, again, quite a bit of literature. So, you know, as we're looking at things, we say, all right, we need to start treating these impairments. That's really under the quality of life umbrella. We know that palliative care is there. We know general exercise is there, nutrition and psychosocial, and we need to make sure that cancer rehabilitation is there too. This is all under this quality of life umbrella. It's all part of the different components. Looking at medical care delivery, quality and safety, this has been something that amongst physiatrists and rehabilitation professionals, we've been talking a lot about safety in cancer rehabilitation. These patients are often very sick. They have comorbidities. They are getting treatment after treatment, either sequentially or sometimes simultaneously. So it's quite a lot to go through cancer treatment. And there's also been studies looking at sort of the safety in general exercise and weightlifting and so on. And in this study, as you can see, you know, a good proportion of the weightlifting group had to go to a primary care provider that required cessation or dose modification of the weightlifting. So, you know, we do, even exercise, therapeutic exercise in particular that's prescribed, is a safety concern. We have to make sure that we're doing things safely. So in this graph, as you can see, you know, we're looking at where we have the most control and where the quality and the safety is the highest. And that's going to be with the therapeutic exercise from, for example, a physical therapist and so on, and treating impairment. That doesn't mean that everything has to be done by a physical therapist. What it does mean is if the patient has impairment, then it really does need to be seen by, that patient needs to be seen by a clinician that can prescribe the appropriate treatment. And then, of course, when you have control over your fitness classes and so on site, your quality is going to be a little bit better. And then when you go off site, you have a little bit less control. Community programs are really, really important. We want to have those. We want to triage patients to these programs, but we want to make sure that we do it safely and appropriately. So the 2013 report that talked about delivering high-quality cancer care put the patients in the center. If you haven't seen this, this diagram, this is straight from this report, and it's an interconnected, 6-part interconnected framework where we have that patient-centered care, and then we have this trained interdisciplinary team, and then all clinicians are focused on these quality measurements and so on. And this, the value base for this really has 3 stakeholders. It's those patients, it's the doctors, and it's the payers. And so high-quality program is going to make the patients happy, it's going to make the doctors happy, and it's going to make the payers happy. Part 4 is really this access to care, screening, referrals, and reimbursement. So we talked a bit about the access to care in terms of how we're going to triage patients. And one of the things that a lot of people think is that the Commission on Cancer just came out with cancer rehabilitation as a new requirement, and that's actually not true. It's not new. The American College of Surgeons has had cancer rehabilitation as a requirement, as an eligibility requirement, it's E11, for quite a number of years. But what's new is that they've really been thinking about, well, gee, how do the new standards, 3.1, 3.2, and 3.3, really drive cancer rehabilitation? How, the navigation process, how are these patients being screened and appropriately triaged, either to fitness or to cancer rehabilitation clinicians? Standard 3.2 is this psychosocial distress screening, and we know that there's this really strong link between distress and physical impairment, so that's another component that's driving cancer rehabilitation care. And then, of course, the survivorship care plan is really about documenting the services that patients got and making sure that they get good follow-up care. So one of the recent reviews focused a bit, and we're talking about screening and access to care and so on. One of the recent review articles is something that we've been talking about a bit in the physician world of things, talking about, wow, some of these patients are really sick. They're older, they're very sick, and the title of this review article, The Elephant in the Operating Room, sums up what is happening in a lot of hospitals, in every hospital really around the country, which is that, that these patients are very sick and high risk. So Franco Carli is a physician in Montreal, and he has been writing a lot and doing a lot of research around prehabilitation. And this is a brand new review article that he wrote. This is an advanced copy that I'm showing you here. And I love this first line that he says: tissue trauma, physical inactivity, quasi-starvation. Quasi-starvation, that's that perioperative period where we don't let people eat. And psychosocial distress represent major stresses to the body. So here we have this older person who's high risk anyway, and we're going to do tissue trauma to them. We're going to keep them physically inactive, and they probably are anyway. We're going to starve them, and then we're going to create a lot of psychosocial distress, and we're going to hope that they do really well post-operatively. Well, prehabilitation is certainly something that people are thinking a lot about. So let's talk about sort of what usual care or usual care plus education looks like versus prehabilitation. And the big difference here, the differentiating component here, are you driving specific outcomes that you're measuring? And I always say, if you can't make a chart or a graph from it, you're not really doing prehab. So what baseline measurements did you take? And then what specific interventions did you do? And did you reassess the patient? And can you show progress so that they're actually, by the numbers, doing better? When we look at prehabilitation and we think about certain populations, for example, lung cancer patients, there's some good literature on prehab in lung and in colorectal and in prostate. and in head and neck cancer, we say, all right, we know that in these populations it probably really makes sense to do prehab, but what if they already have impairments, or what if they're already very distressed? Well, of course, we want to screen them and make sure that we triage them appropriately. So prehab is really the first opportunity to do a screening. And that's where you're going to get your baseline. That's where you're going to be able to say, how much did cancer treatments really affect this person? What did they start with? You're going to be able to get rid of some of your musculoskeletal, your metastatic workups for musculoskeletal problems. And you're going to pick up problems early. And this fits right in with the prospective surveillance model as well. Now, when you think about prehab, you're starting there at baseline, and if you offer them specific interventions that physically and emotionally help them to be stronger prior to their cancer treatment, then you're going to expect them to not have as many problems, not get as bad. You may be able to prevent some impairments, and hopefully you'll be able to lessen the severity of some of the impairments that they do develop. Here's something that's interesting that we've seen in small groups, that some of these patients are actually better off. They're stronger, physically stronger, and really doing a lot better after their cancer treatment than they were at baseline. That is a game changer, because right now almost everyone expects every single cancer survivor to be worse than they were at diagnosis. Prehab is potentially a game changer, and we've seen that in small studies in certain populations. So looking at reimbursement, Medicare, Blue Cross Blue Shield, and so on, they pay for almost all of the cancer rehabilitation interventions, but they don't pay for general exercise and wellness. So it's really important, as you know, on the hospital side of things, on the clinic side of things, as you're trying to build up a reimbursable, sustainable model, that you add the reimbursable services that these patients desperately need that help support your institution. So a lot of times what happens is people will say to me, well, okay, we want to just fast track things. We want to fast track. We want to identify the patients that have impairments, and just maybe we'll just focus on breast, and we don't really think thyroid cancer or skin cancers, melanomas and so on, we don't think they really need rehab. And one of the reasons why I pulled this study is because it's brand new, just came out. It's I pulled it ahead of its print publication here, and you can see it's the date on it. And this is thyroid cancer, which a lot of people assume has a great prognosis, which very often it does, and that these patients are all set and fine. But look at this. They're saying here, their health-related quality of life is affected even though they have a good prognosis. And in fact, these patients have persistent restrictions in regaining their normal daily life in terms of work and leisure. Wow, that's really important. We need to really pay attention to this and not assume things. The way that we get around assuming things is to, number one, look at the research, and number two, screen. We have to be screening these patients. We cannot make assumptions. So where would you do the first screening? Here, when they're diagnosed before their cancer treatment starts. You could certainly do another screening here after their acute cancer treatments. And then you'd want to make sure and screen them after they do rehab, prior to sending them out into the community or whatever. So here's 3 places where you could screen and really have a significant effect. I've written about and I talk about a lot dual screening. Dual screening is something that I have sort of coined that term and focused a lot of my work on this idea of not only distress screening, but making sure we're screening for physical impairments and documenting them and triaging patients appropriately. So a lot of hospitals now, because of the COC standards, are doing distress screening, but we really need to pair that with physical impairment screening as well. So what does reimbursement look like? People are often wondering, well, what does reimbursement look like? And I know if you're a clinician who's a rehabilitation clinician, I know you know this, but on the oncology side, a lot of people don't realize this, that Medicare reimbursement actually is in a couple of buckets. And it really doesn't matter if you've been in a car accident or you've had a stroke or anything else. It's the same bucket of money. And in fact, if you can document medical necessity, you can get more than this cap here of $1,900. But the caps really mean that we need to treat a lot more patients and we need to see them for fewer visits. And that's how to drive better care for these patients, high quality care, and also reimbursement for your institution. So instead of getting a patient who has never had rehab and has many, many, many problems and is going to need lots and lots and lots of therapy, we want to get them earlier, see them for fewer visits, get them through that surgery, etc., and stronger and healthier with a better outcome. And this fits right in with the Institute for Healthcare Improvement. Even if you've never heard the term triple aim, this is what everyone's talking about. This idea of improving patient satisfaction, improving the health of a population, i.e. cancer survivors, and then reducing the per capita cost of healthcare. So you basically have to make your patients happier and healthier, but you have to do it for less money. And that's a three-part thing that is very difficult to do. But rehab fits perfectly within the triple aim, especially when you screen these patients, you identify problems early, and you even prevent problems from happening. It fits right in with the triple aim, and the triple aim is very, very hard to do, but rehab is so synergistic with it. So here's Tim Sherwood. He's a thoracic surgeon, and he works at Mary Washington Healthcare. And he has been sending a lot of his patients for prehab and for rehab. And one of the patients I was talking to, and she's lovely, and she said, you know, Dr. Sherwood told me that I just was not a good candidate for the operating room, that I would likely end up in a nursing home and I just wasn't going to do very well. And so he made me go to prehab for a number of weeks before I had surgery. Then she had a successful surgery and she did great. And in fact, she was even stronger after surgery than she was before. This is a case study of what I was showing you earlier, which is that someone that was stronger and healthier and better after their cancer treatment than they were at diagnosis. This is pretty exciting. So just to kind of show like what this looks like in terms of, you know, can this be done? Can we actually screen patients? Can we actually get them to rehab? Does this actually increase our revenue and so on? And the answer is yes. Yes, absolutely, this can be done. So this is, you know, this is just an example of the kind of growth that you see, you know, how many referrals go over, and so on. Of course this can be done. I mean, you know, it's like asking, well, can we really treat women with chemotherapy who have breast cancer? The answer is, of course we can. But, I mean, there's a lot of things to put into place to get that to happen. And this is another healthcare system just to kind of show, like, what this looks like and how this can be done and so on. So what are the doctors saying? Well, they're saying a lot of things, and one of the things that I've asked my colleagues to do is I've asked them, I said, you know, you tell me that you think rehabilitation is great. I want to share your thoughts with other people. I want people to know that the doctors are on board. And so I asked a number of my colleagues to just kind of, you know, share their thoughts and so on. And, you know, this is what they're saying. One of the things that I like about what Dr. Brooks said is that he's really, you know, telling his colleagues, you know, no oncologist should allow patients to suffer needlessly. And that's really what we're talking about, is the unnecessary suffering. We know there's a lot of suffering in cancer, and we know a lot of it cannot be alleviated, and we can't prevent a lot of it, but there is a lot of unnecessary suffering. So that's what we're talking about. So he's calling on his colleagues, oncologists, to really step up and say that cancer rehabilitation is important and we have to implement this. And then Michael Seiden, he's the president and CEO of Fox Chase, and you know, again, he's calling on his colleagues. It's time that oncologists engage with experts in cancer rehabilitation to better predict which impairments might arise, etc. So, you know, he's again calling on his colleagues to really step up and to make sure that these patients get the care. And this is Andrea McKee. She is a radiation oncologist, and she is terrific. And, you know, I love what she says here. Patients already intuitively understand that prehab will benefit them. It has taken the medical community a little bit longer to catch on. And I think that's a really important point. There is research on prehab. You know, definitely important to look at it. Not everything is considered prehab, and it's, you know, it's important not to just wing it. So here we have the survivorship care puzzle. This isn't meant to include every single piece. There's lots of pieces here that are not included, you know, just for representation. But that central piece of cancer rehab is really important. So what do we have next on the horizon? I think there's a lot of things. I could make a list that's twice as long, 3 times as long as this. But, you know, there's a lot of exciting things on the horizon for all of us on this webinar now who are concerned about survivorship care and whatever your role is, whatever kinds of things that you are doing. You know, they're really, really important. And I know we're going to get to a Q&A component of this too, and please do feel free to send in questions that you have now if you want on different things. This is a very exciting new initiative, and I wanted to share this with everyone. This is the first time ever that subject matter experts have gotten together through the NIH and the NCI, and we've been talking about how to really expand these services in the United States and how to really offer this evidence-based or best practices care. And so that is you know, coming up. This is a free conference. There is no charge, and if you are interested in attending, you certainly can attend. You just show up, and we are happy to have you listen to the results of what these subject matter experts have come up with. We've been working hard all year on this. If you do have questions, by the way, enter your questions on the bottom right and send to all panelists, and we'll see those. So if you go to enter your question on the bottom right and just send it to all panelists, and we'll see that. So one of the things that we've been talking about behind the scenes as we've been working in work groups, there's actually 4 work groups from this, you know, consortium that has been brought together. And one of the things that we've been talking about is that there's a lot of stakeholders in survivorship care. Many of you are on, probably most of you are on this webinar because you have an interest, because you're a stakeholder in survivorship care, in rehabilitation care or oncology care and so on. And what we believe will happen is we're going to make all these recommendations, and we're going to see some groups really step up and lead. And we're excited to see that. We don't know who it's going to be. We hope it will be the American Cancer Society. We hope it will be a lot of other groups, NCCN, and we hope it will be certain hospitals and so on. Of course, we'd love everyone to step up because there's so much work to be done. And, you know, the more we work on this together, the better. But we know that probably won't happen, that some groups will be distracted with other things or have other priorities. But there is opportunity to really step up and do some wonderful, wonderful things to help support cancer rehabilitation care in the United States. So we're excited about that. I'm happy to answer any questions offline, but also happy to respond to your questions now as we are online. And thank you so much for your attention with this webinar, and thank you to the American Cancer Society for sponsoring it. I'm going to just see. Catherine, are you back on?
I am, yes. So now is the time. Anyone who's out there, I see there's still 225 of you with us, so feel free to enter your questions again in that lower right box, and then when it says send to, make sure you choose all panelists, and we will see it.
I'm scrolling through, and I see a lot of audio things that hopefully were solved, and I'm just going down to the, let me see if I go down to the bottom here. Okay, here we go. We got a number of questions here. So All right. So our cancer center is a joint venture with a few hospitals. We provide the medical, radiation, oncology, and want to provide a more formalized cancer rehab program. When we refer, are there specific areas, templates that are available? So that's a good question. You know, I think that there's a lot of information out there now that we'll be talking about again at this dissemination conference. They're, you know, pulling together a cancer rehabilitation program definitely requires some research into what the best options are and so on. My work has been very focused on helping hospitals to bring together cancer rehabilitation service lines, so that's very much where my work is focused, and you can certainly look up a bit more about my work in that area. Catherine, do you have any comments regarding that?
No, I think that was great. Let me jump in and answer a couple of the other questions. So one, where is the NIH conference? Good question. So that's held at the Natcher Auditorium, which is on the main NIH campus, which is in Bethesda, Maryland. And another question, Dr. Silver, I'm going to send this one back to you. This is a really important question. You know, we have both talked about the need to screen people, to screen all of our cancer survivors, and multiple times using that prospective surveillance model. You know, is there a best practice, or is this NIH group, can you talk about what a best practice tool would be to do that screening? And then who does it is the question.
Great. So good question. There is no single tool. And I don't think it's possible to find a single tool. You know, cancer is more than 100 different diseases. And to basically say, okay, we're going to use this one tool and that's it, and that's all the screening we're going to be doing, just would not help the patients enough. So in the hospitals that I work with, you know, we have a number of different screening tools that we use based on the diagnosis. And it's something that at the NIH, the work group, I can tell you the outcomes work group has, you know, come up against the typical struggles with lots of different tools, lots of different gold standards and so on. But that's where really getting sophisticated about cancer rehab, there are solutions, but there's not simple solutions. There's not just use this tool and you're all set. It doesn't work like that. And it's really important not to reduce cancer rehabilitation to something so simplistic because that's just, that will not work. But there definitely are screening tools, protocols, and so on that can work depending on the patient population and so on. There's a question about how important is physiatry, and that's a question I get asked a lot. There's not enough cancer rehab physiatrists in the United States right now. And it's something that we've been talking about a lot on the NIH NCI consortium, basically the supply and demand. There really haven't been awesome opportunities for cancer rehab physiatrists in the past because not very much cancer rehab was done. So people that got into it, like me, did it really out of a passion rather than a sense of, you know, we got this great training during our residency and there are all these amazing jobs when we got out of residency and so on. It wasn't like that. So as we, you know, sort of progress, one of the things that will be interesting to see is whether physiatrists do develop more training programs, they do get more engaged, and there are many more physiatrists that are trained. The same is true with physical therapists, occupational therapists, and speech therapists, by the way. They also have not had the training and so on to really be highly skilled oncology clinicians in general. So, you know, there are certainly people who have gone above and beyond and done this training, and the APTA is working on trying to provide more training for the, or at least not training, but the certification, or there's something else that they call the APTAs, but for the physical therapists, which is great. So the short answer is that there's not enough cancer rehab clinicians in general, but that there's opportunities to bring clinicians together, to train them better as interdisciplinary teams, and to really focus on improving the care. What is included in a prehab screening, that depends. There's a lot of things that are included in a prehab screening. Again, these are clinical protocols. This isn't, you know, a simple solution in terms of, you know, there's this one thing that's done. But for example, prehabilitation is multimodal at its best. In the early prehab studies, it was generally just exercise and fitness only, and that didn't work really well. In fact, in at least one study done by Franco Carli, the patients actually kind of crashed as they, and if you think about this, it makes sense. If you think about taking someone who is someone who's older and has comorbid conditions, and you do a lot of exercise or even a moderate amount of exercise right before they have surgery, and then you're going to starve them in that perioperative period and so on, you're probably not going to have them do very well. So multimodal prehab is really what we've been researching and looking at, and that really involves psychosocial interventions. It involves nutritional interventions, and not nutritional interventions such as eat your fruits and vegetables, but very specific nutritional interventions that have to do with protein and glycemic control and so on. So again, this is clinical care. It's very sophisticated care. I'm trying to see.
Dr. Silver, what about the question about where do you see cancer rehabilitation done? Outpatient, inpatient, community settings? I mean, my answer to that is everywhere it can be, but it depends on your particular community. But I'd like to hear your take on that.
Well, I agree with you. I think that's exactly right. I mean, wherever cancer care is, so wherever oncology care is delivered, cancer rehabilitation should be delivered in that same area. So if it's a hospital, if it's an outpatient clinic, wherever it is, and the COC basically says that cancer rehabilitation has to be offered on-site or by referral. So that's a COC accreditation requirement. But it's not, you know, this again is clinical care, so it should be in clinical settings. Most cancer rehabilitation, by the way, is going to be ambulatory. It's going to be outpatient because that's where most of the cancer patients are. But you're going to see cancer rehab in subacute nursing facilities. You're going to see them in inpatient rehabilitation facilities and so on. So someone said, I like this comment, I'm a breast cancer survivor, and she related to the carpal tunnel surgery and the trigger finger and so on, and said, very interesting. Well, thank you. I'm glad you got something out of that, because I think that you know, a lot of times that saying in medicine that many of you know so well, you know, the mind doesn't know what the eyes haven't seen. I get so many questions about lymphedema. And I think lymphedema is really important, but in breast cancer, the minority of patients have lymphedema, and the majority of patients have other musculoskeletal problems that are really problematic. And as the woman just wrote in, you know, they were to her, she ended up with surgery for carpal tunnel syndrome, et cetera. So who does screening? Good question. Someone who, a clinician who's trained, that's really important. I really try to make sure that whenever I speak, that I convey the message that no one should be dabbling in cancer rehabilitation. We shouldn't be dabbling. This is medical care, and this requires experts to really drive the outcomes to decrease disability and so on. So, you know, this has to be people that are trained to do the screening. Now, sometimes screening can be done with patients filling out certain forms, and also a clinician doing certain physical function tests, and also blood tests, and all kinds of things like that. And that's, you know, that's the combination of those are involved in various protocols.
Well, I'm aware that we've run out of time. I see a number of concerns about, you know, can we have access to the slides, and this presentation has been recorded. I'm wondering if I can ask Stephanie to come on and talk about where people can access the podcast.
Sure, you can. This is Stephanie Van Winkle with the American Cancer Society. We have recorded today's call, and it will be converted into a YouTube video. And I've already sent out the presentation via a Dropbox. I do understand that some people are not able to access that from their work computers, but it does seem like the easiest way to send out because the file will be large. So for those of you on the call, if I do send out any additional information via Dropbox, I'll note it in the email I send out, and you can email me to let me know if you can't access via Dropbox. But we will be sending out the call recording to everyone on the call.
All right, thank you. And thanks to everyone who joined us, and especially to Dr. Silver for her time today. Thank you. Bye-bye.
Thank you.